This is Dr. Mark Krasnoff. I've been a member of Physicians for a National Health Program for many years now, and I'm here to present the problem of surprise medical bills and how improved Medicare for all can solve this problem. I'm going to talk first about what a prevalent and bothersome problem surprise medical bills are, and I'm going to discuss the severity of their impact on people and then get into the details of how they come about and how they occur. The main overall reason they occur is twofold. It's because the current private insurance system, all of our health insurance programs and the various types that exist throughout our country depend on a system of networks where contracting is done every year between insurance companies and providers and hospitals and device companies and pharmaceutical companies. And all this contracting creates a lot of networks. And if you go out of network, you get stuck with a surprise medical bill. It's completely inefficient and harmful to people, and we will get into that. The other part of it, aside from the presence of networks, is the presence of bills themselves. When you have to bill patients and patients have to receive bills, you get into all the complexity involved in deciding how to divide the medical pie, how the complicated process of extracting money from people is carried out, and surprises happen. So prevalence of surprise bills is significant. Over half of people, 57% as of December, have been surprised by a medical bill that they thought would be covered by their insurance. This does not include the expected costs that people may be aware of, such as co-pays, deductibles, co-insurance, a significant portion of healthcare that is paid for directly by patients when they access the system. But this is about a surprise bill beyond that, where going out of a network accidentally or because of medical necessity creates an exorbitant bill which falls on the patient rather than anyone else. This has become a much more prominent problem over time in terms of how many patients are affected. Privately insured patients with out-of-network billing occurred in about a third of emergency room visits in 2010, and that went up to over 42% in 2016. Hospitalizations used to include a surprise medical bill 26% of the time, and now that's up to 42% of the time. So this is really an incredibly prevalent problem when you think about it. Normally a system that functions as expected doesn't have surprises at all. And this is a system, if you can call it that, that has a 42% rate of causing surprises in patients' bills. If you went to a restaurant or a store and every time you shopped, 40% of the time you received a surprise bill, the economy would not function. Now the plans of insurance often don't pay anything for out-of-network care. So if you happen to get care outside of your network, you're very likely in a small group plan to have to pay the entire cost of the out-of-network care. And if you have individual plans for insurance, it's up to 71% of those as of 2018 that provided no coverage whatsoever if you were seeing a doctor or getting a test that was in a network outside of the network contracted with your insurance company. So insurance company networks and limitation of choice are driving the problem. People seek and receive medical care in the best way possible for their health, but it's not the best way possible for their pocketbook because there's no way to organize who takes care of you and how your care is dispersed to different people and keep that all within a network. It just can't happen, and that means surprise medical bills are going to keep occurring. How much money are we talking about? For an emergency room visit, it's up to $628 on average as of 2016. This is now almost 4 years ago, really. The average cost for a surprise bill in an emergency room was $628, which is a pretty devastating amount of money to have to pay for most working families in America. And for a hospitalization, it's even worse, over $2,000 for a surprise medical bill for a hospitalization as of 2016. These bills are financial disasters for most working families, and we're going to talk about how they cope with that. When asked how you would pay an unexpected $500 medical bill, 34% of people say they would pay the bill. That's people like you and me, physicians, if you're a physician, people who are reasonably well off. Maybe not everyone who's listening to that, though, by far, because only 34% of people would be in a position to say, that's frustrating, it's surprising, it's irritating, it's going to interfere with some other things I'd like to do with this money, it's going to disrupt my life potentially in many cases, but I can pay it. For other patients, it's not so easy as that. 7% would make an arrangement with the doctor or hospital to perhaps pay the bill over time or lower the price. Some might put it on a credit card and pay it the next month. It might affect their other expenditures, but they might be able to get by with it that way. 20% would have to pay with a credit card and then pay interest on the credit card over time. So they wouldn't only be cutting back on other things they may need to do with their money, other important bills they need to pay, they may actually start to have to pay interest on this debt, which puts them in a very vulnerable position financially and creates the risk of bankruptcy eventually when you start adding up the costs of medical care. 7% would have to borrow from someone, either a friend, a family member, a bank, a payday lender, someone who would lend them the money, and then again, they'd be paying interest outside of a credit card. And about 19% of people would just be unable to pay. They would go into arrears and they would start facing collections calls and the stress of that, which no one would ever want to experience. So that's what happens. This is the percentage of adults who had to borrow money or reduce spending due to healthcare costs. So surprise medical bills are one major cause of that, and this is the kind of consequence. 12% in this survey have borrowed money to pay for unexpected medical costs or medical costs in general out of pocket. People have cut back on groceries. 70% of people have cut down on purchasing clothing, over-the-counter drugs, utilities, recreation. All of these things are economic activity that is limited and stymied by the cost of healthcare. And those are things people have to sacrifice when they get stuck with something like a surprise medical bill. This is a demonstration of the percentage of consumers who receive collection calls with different types of debt. And as you can see, medical debt far exceeds all other types of debt in terms of the percentage of people with calls about their debt who are being asked about a bill for a medical service or supply. So 59% of people said that medical costs were a cause of their collection calls. 37% telecom, 28% utilities, 21% about paying their taxes, 14% legal and court costs, and 11% rent. So you can see medical costs lead the way when it comes to stressing people with collection calls. So what exactly is a surprise medical bill on the ground? Like, what happens to make a surprise medical bill occur? Well, in one situation, you might have an emergency, an auto accident, a stroke, a heart attack, a fractured bone, a sports injury, and you go to the closest hospital, and it turns out that that facility is entirely out of your network. You could be stuck with a very large bill for this, and some states have made efforts to try to limit the cost to you if you have a true medical emergency, but it's quite a hassle to have to demonstrate the severity of your emergency even in those situations. And this can be a very devastating source of financial strain in a situation where you really have no control over what happens to you. You're just seeking the care you need, and you end up with an unexpected bill. Now, you might go to a hospital which is actually in network, the hospital emergency room or another facility, and something gets done that's out of network. A physician may see you who's not in the network, even though the institution you're in, the hospital you're actually in, is in the network. This happened to a very close relative of mine. She went to an emergency room, and it wasn't the anesthesiologist or the radiologist or an assistant surgeon or a pathologist. It was actually, in her case, the emergency room doctor himself, who was not in the network. The hospital had contracted with a separate group of doctors to provide the emergency care in their emergency room, and yet the emergency room physicians didn't have a contract with every patient who had insurance who could come to that hospital because their insurance had a contract with the hospital. So these patients actually show up in a hospital in network, see a physician that's out of network, and get a surprise bill. And these can come from many, many sources. In my relative's case, it was the emergency room doctor. In these cases, they talk about the percentage of other specialists that are a little more hidden in the hospital that might actually end up billing you directly for a charge because they have no contract with your insurer. Another problem that can happen is the insurance directories can be confusing and incorrect, and the networks can change. And you might think that you're going to be covered, and then you're not. Or you might get a surprise like this. I had a person I was meeting with one time who told me he was a retired corporate lawyer. He had kidney stones, a painful condition, as we know. And the night before he was due to go into the outpatient facility for lithotripsy to break up his kidney stones and relieve his problem, the doctor called him and told him, "We have to postpone your lithotripsy because the facility where we were going to do the lithotripsy is not on your insurance, even though I'm on your insurance." So this person got a surprise medical bill in the form of a surprise delay in care and pain, suffering, perhaps inability to work, other functional problems. Those are costly things, even if they're not direct medical bills, and they're a consequence of a surprise in the network under insurance. You might also show up in a facility and get the treatment, like the lithotripsy, only to find out later that they weren't in network, and then you do get stuck with the actual financial bill to face that cost. And then there's the example from NPR earlier this month. Kaiser Health News presented the story of a woman in New York who went to a private doctor's office with a sore throat and respiratory infection. She was going to be traveling soon and wanted to make sure that if she were going to need antibiotics, she got them before she traveled. And they did a throat swab and a nasal swab to look for causes of her infection. And they decided she did not need antibiotics. And when she got back from her trip, she got a bill for that visit of $2,500 as the copay for a bill that was over $28,000 for the cost of out-of-network lab testing that was done on the sample from her nose. Now, it was inappropriately done in the outpatient setting in a situation where a patient wouldn't normally have that test done at all. If the test had been done at a lab that was in network, it would have cost over $600. And out of network, the lab actually went ahead and just charged $28,000. The insurance company was prepared to cut a check for $25,000 because a lot of this isn't really run by human beings case by case. It's a computer, and it gets the bill and it pays the bill. And she was going to get stuck with the $2,500 copay, and then they were going to work out a way to waive the copay. But she, of course, realized how crazy this was and brought it to everyone's attention. That's an extreme example. That's the kind of thing that makes the news. But the type of problem that it represents is not unusual at all. And the amount of money is less than $28,000, but as we saw, very substantial. If you have an emergency room charge or a hospital charge of $600 or $2,000. And in this case, if it had been an in-network charge, it would have been over $600. So these surprise bills from being stuck out of network are really devastating and disruptive, and our system just doesn't solve those problems. And then there's the subject of balanced billing. That's where the insurer does work out, in some cases, that they will pay a portion of the care, even though it's out of network. They have a way of paying some of it, not as much as they would have paid in network. And then the patient pays their share of what they would pay under their insurance in an out of network situation. Or maybe they even get a mitigation and an argument that results in them only paying what they would pay if they were in network up to that point. But the recipient of the payment, the person who provides the services, has no contract with the insurer. So even if the insurer offers to pay their share and have the patient pay their share under the insurance, the provider of care, the hospital or the lab or the doctor, can still balance bill the patient for a higher charge based on what they would charge the patient not having any kind of insurance contract with them. And that's balance billing, and that's a major surprise and pain for patients who have health insurance and yet still get stuck with surprise bills. So how can we solve these problems? Which of these types of problem of surprise bills can be solved by a public option, an alternative to Medicare for All, where we just provide yet another insurance company, this time a public one, to compete against the private ones to try to get patients and set up networks for their care? Well, a public option does nothing for any of this, really. In the case of emergency room care, where you show up in the emergency room and it's not in your network, if you're out of network for a public program and all the private plans that still exist and people keep their private insurance, it does nothing to solve their problem of having networks and going out of network. A public option might be very broad and have no networks even. You could imagine a public option where they say we have no network and you can see any person, but only the people who are in that public option would actually get that solution. Everyone else in their private insurance and the rest of the industry would not be affected, and we would still have surprise billing from emergency room appearances. Medicare for All doesn't let that happen. In Medicare for All, there's only one payer. There's only one network. The network is the entire country. We're all in the same risk pool together, over 360 million Americans. All facilities are covered. The patients never receive a bill directly. All the billing is done efficiently between the providers of care and the single payer represented by the Medicare program. And they pay the bill 100%, and the patient never sees that bill. The patient pays that bill in the form of all the taxes we already pay: income taxes, property taxes, sales taxes. And the Medicare program has enough money through those taxes to make it very effective at paying good prices for providers of care and reasonable prices for patients on their behalf, because we already collect enough in taxes to cover this sort of thing. Hospital care, where you show up in the emergency room and the emergency room doctor or the anesthesiologist happens to not be on your insurance network, public option, again, doesn't solve that. Private insurers can still refuse to cover out-of-network physicians. There will still be private insurance if there's a public option, and there's no guarantee that people in the public option would not have networks that restrict them as well. Medicare for All solves that problem. There are no networks, there are no bills directly to patients, and so there are no surprise medical bills. Insurance directories, where you have some people in the network, some people out of the network. The network can change. A lab might be in 1 month and out the next. Those problems persist with the public option, but they don't persist under single payer Medicare for All. There would be no directories. All hospitals and providers would be in the program, and therefore you would never have anybody out of network, because the network would be the United States. Balance billing, again, the same story. Private insurers can still refuse to pay out-of-network providers at all based on the percentage you saw earlier of insurance companies who provide nothing for out-of-network care. The private insurer might provide something for out-of-network care, but it costs the patient more, and sometimes it can be a big surprise. And then the institution that's billing the patient can bill them above and beyond what the private insurer and the patient pay under their insurance plan, because they have no contract with the insurer or the patient. And they may say, well, we charge more for that when we don't have a contract with you, and this is what we charge. Under single payer, the real Medicare for All, patients never get a bill directly for medically necessary services, and therefore there's no risk of balance billing. Everyone is basically under contract with the single payer to receive what's expected for their services, and it relieves the providers, the doctors like me, of the burden of having to deal with multiple insurance companies and billing patients who can't afford to pay and billing patients who have no insurance, being reimbursed by the government for care that's provided in a hospital for uninsured patients. All those extra payments, somebody pays for that. And under single payer, it just doesn't happen anymore in a way that's so disruptive to both doctors and hospitals and patients. All the administrative burden of haggling over who pays for what and what the prices are is solved in a single payer program. So when asked the question, do you support or oppose legislation that would protect patients from paying the cost not covered by their insurance when they receive care from a provider or hospital who's not in their network? 84% of Democrats support solving that problem and making sure that patients don't have to pay that out of pocket. 14% oppose it. 78% of independents favor solving this problem, and 71% of Republicans favor solving this problem. So on average, it is about 78% overall of people who agree that surprise bills shouldn't happen and that we should have legislation to protect patients from it. But that's really overlooking the fact that we've got a divided system where you have limited choices of where you could go for your care, and the private system of insurance limits your choices, and therefore you're at risk of going out of network, and it's part of their business model that they don't have a contract with everybody, and they can't help the fact that they don't have a contract. So they're gonna say, well, that's all well and good, but our business won't work if you eliminate the burden to the patient, and somehow we have to pay for that or work out a negotiation with somebody we don't have a contract with. So we'd all like to solve this problem, but doing it piecemeal through our current system is really not feasible. Only a single payer program, Improved Medicare for All, really addresses every aspect of this problem and eliminates surprise bills completely. So why is single payer Medicare for All the best answer? It's simple, it's transparent. It doesn't have any of the complexity and billing difficulties of our current system. It provides comprehensive benefits for all Americans. It will include dental, vision, hearing aids, all medically necessary services. It won't cover LASIK surgery, but it will cover refraction, it'll cover eye care, it'll cover hearing aids, it'll cover dental care, which is something that is so vital to people's health and that costs us so much in downstream costs when people can't afford dental care and get serious physical medical complications from having poor teeth and getting bacteria in their bloodstream. Any doctor or hospital or pharmacy across the country is covered under single payer. It's everybody in, nobody out, and that goes for the patients and the doctors and the pharmacies and the medical equipment device makers. Everybody is in one system, and the negotiations are transparent and above board, and we can make it so that people pay a reasonable price for the care we expect to receive in the form of our taxes, and the government negotiates on our behalf a reasonable price and reimbursement, and nobody has to have all the hassles of billing every single service that's done. No copays, no deductibles, and no surprise bills. Copays and deductibles deter people from seeking medically necessary care, and some of those patients are going to have expensive, complicated problems later on that they can't afford to pay for and that cost the whole society, in many cases making them disabled and not able to contribute anymore. So putting up barriers to care and interfering with preventive care, interfering with basic medical care, and then agreeing that we're going to still take care of you when you break your leg or have a heart attack or a stroke is just an inefficient way to take care of people. It doesn't make sense on a human scale in terms of human suffering, and it doesn't make sense economically. And surprise bills are also completely eliminated by Medicare for All, as I noted. This also, single payer Medicare for All, gets American businesses back to business. No longer will human resources departments have to worry about the cost of the healthcare problems that the employees of the business might encounter. If you want to hire a 55-year-old with great experience who's going to add a lot of value to your business, you don't have to worry that if he or she has a health problem, it's going to take away the benefits of having hired them, because the cost of their health care goes beyond and exceeds the asset that they are to your business. And that just doesn't make any economic and business sense. To have businesses in the business of negotiating healthcare contracts and dealing with all the problems with that complicated system we have just detracts from the efficiency of American businesses and our competitiveness at home and around the world. The cost of healthcare in the United States is making America less competitive, and we need to let American businesses get back to what their business is, not to being contractors for insurance companies to try to take care of their population's health care when they're really just trying to take care of their employees as employees. And Americans are proud of Medicare. The original Medicare banned any private insurance company from participating or duplicating Medicare services. And people did not complain in the 70s and 80s about the fact that there was only one Medicare and they could see any doctor or go to any hospital and it would accept Medicare. A very small percentage of doctors didn't accept Medicare, and under an improved Medicare for all, that percentage would be even smaller, very, very small, and patients really could seek care based on where they think they can get the best care. And doctors and hospitals can compete in a free market of competition to attract patients and to perform well and to have good outcomes at a reasonable price. And all of that can be visible and transparent so that people know whether they're doing a good job of that or not. Physicians for National Health Program is a nonprofit, nonpartisan, member-supported 501c3 organization that's been around since 1987. Membership is open to everyone. Actually, I think 86 before my time as a doctor. www.pnhp.org is a great resource for information and data about the problems we have in our system now and how a single payer system solves them. You can also see us on Facebook at facebook.com. And for more information and resources on surprise billing and Medicare for All, visit pnhp.org/kitchen table. We're going to be discussing other issues in the coming months. Racial health and inequity will be the theme of February's presentations and discussions. Rural health care will be the subject in March. High drug prices in April. Maternal and reproductive health in May. And substance abuse and opioids in June. All of these issues are significant problems in our country, and all of them can be addressed much better under single payer Medicare for all than they're being addressed now under our divided and inefficient system. I'm going to say a few things about some other subjects, questions people might have. For example, why is it that we can't just get Congress and the states to solve this problem of surprise medical bills without involving a single payer program and a complete overhaul? And if we can't get this surprise billing problem solved, how are we ever going to get single payer national health insurance through? And my answer to that is that getting single payer health insurance through is politically difficult, and that's the only argument against it. The piecemeal effort to solve all the many problems of our current system, such as surprise billing with laws in individual states and acts of Congress to say patients can't be held accountable for a surprise medical bill in an emergency, all those things, even if they could pass, would not solve all the other problems that exist. And meanwhile, while the arguments are happening and special interests are interfering with the process, people are suffering, healthcare is being denied and delayed, medical bills are being sent out, people are being put under financial stress, and it's interfering with the health and happiness of our society. People ask, how can you just know? How can you just find out and know about which doctors in a hospital aren't in network and just make sure that there's a law that says, well, the doctors in the hospital who aren't in network can't be the ones to see you? Well, now you're disrupting the entire system the hospital has for trying to deliver efficient care. They need to have doctors on staff and showing up at the right times, and they can't base their work patterns on the mishmash of different insurances that may be serving patients who show up in their hospital. It's just not possible for them to make sure that on top of everything else, everybody's got a contract with every single insurance that might come to the hospital. And so it's just not a very practical solution economically. It's a very big cost for people to have to deal with those things. Another question that patients might ask and doctors might ask is, well, what does this do on the provider side? If a provider who's been getting income from a surprise medical bill can no longer bill what they think is a fair price because they just don't happen to have a contract with an insurance company, how can they be reasonably reimbursed by patients who are out of a network that they're not a part of? And the answer to that, of course, is that doctors really would be better off if we didn't have to deal with the hassle of billing patients and finding out what their insurance is. The cost of doctors' offices and doctors in hiring people to do their billing and then doing their collecting and then sending people to collections, all of that is wasteful and inefficient. And it would be much better for the doctors' pay and security and dedication to their field not to have to deal with any of that, not to have to bill patients directly, but to have a contract with the single payer United States of America Medicare for All program that says, we pay this much for this surgery, we pay this much for these radiology services, and you just get paid. The computer pays you. It just goes through electronically. There is no hassle or negotiation at the point of sale. It's established what you get reimbursed. Everybody knows it, and you don't have to hire a staff or an army of people to fight for your proper reimbursement. It's just much better for everybody from the provider side and the patient side. And the final point I'd just like to reemphasize is how a transparent system where there's no complexity of billing and everyone knows what they're getting from their healthcare providers based on what they get when they go to the doctor and not having to worry about the details of bills, and the reimbursement and financial side of it can be public knowledge and not something that has to be addressed at the site of care, at the doctor's visit, at the emergency room. The payment is there. The patient never has to face that in their moment of stress or trauma. And the government and the Medicare for All program can efficiently reimburse people for providing valuable services to the people of the country. And I think both as a physician and as a patient, I'm going to be very grateful for that when the time comes. I just wanted to make one correction of something I said earlier in error. I mistakenly said that we were already collecting enough in taxes to pay for an improved Medicare for All. The truth is, we're already paying enough in the form of premiums, copays, deductibles, and taxes to cover the cost of a single-payer healthcare system for 95% of us. The top 4 or 5% of people might pay more in total under a single-payer system than they pay now. But in the long run, they would benefit because the current system is unsustainable. The other 95% of the country would actually pay the same or less in terms of their total cost for healthcare in the form of premiums, copays, deductibles, coinsurance, taxes, and surprise bills. So a single-payer Medicare for All is a much more cost-effective option for our country as a whole. Thanks very much. I'm glad I had a chance to make that correction. So thank you very much, all of you, for listening. And please keep track of Physicians for National Health program as we continue to fight for Medicare for All. Take care.